So, welcome to the Ghanaian Obstetrician. Today, we're talking about handover. The safe handover in maternity is critical to safety in the entire maternity unit. Over the years, intrapartum care has involved multidisciplinary teams, and we know that with multiple teams working, the whole care is prone to safety incidents. Teams deal with two patients in one. You're dealing with a mother and a fetus, so the scope of error per clinical episode is amplified. Laboring women quickly transition from low risk to high risk, so it's a very dynamic environment. Now, medical errors continue to occur because most managers assume that errors are just due to a lack of knowledge, and therefore we implement more training programs and more education packages. But we know that in spite of the huge investment in all of these, errors still occur, and therefore maternity units have to focus more on safety, as well as teaching and training. The inter-shift handover is one of the key indicators of the attitudes of an organization or the staff to safety in the workspace. So military pilots, like we know, do not take to the air without a safety brief, and it's essential before you fly. So why is an area like maternity care having people entering the workspace without safety brief? Realize that in the same way, to be able to anticipate problems and to be aware of what is happening in a maternity unit, a handover and a safety brief is absolutely important. So what is a handover? A handover is a transfer of responsibility or accountability from one patient care provider to the next team. So it's normally happening in the morning, midday, or in the evening. And it allows transfer of clinical information of a patient and also resource availability. So it tells you what your staffing situation is, what your bed situation is, what your cord situation is, what your blood situation is. And it allows planning of contingencies for the rest of the day. So at handover, we take stock of what is happening on the labor ward, what is happening on the gynae ward, who has to go to theater. We're able to anticipate problems. If at handover somebody has an abnormal CTG, it means that's first place we want to start. If somebody has a perineal repair that needs repair, that has to be allocated. And enables us to plan for what may happen next and develop a common understanding of the challenges ahead. And this is absolutely critical. The entire team needs to have a common understanding of what challenges are, how many emergencies are waiting, how many perineal repairs are waiting, who is likely to bleed, which CTG is abnormal, so that we can prioritize care and allocate resources. The handover also gives us situational awareness of what is happening on the labor ward and in the ward in total. And have you noticed that this unsafe situations in the labor ward happen when we do not know what is happening? So you realize that anytime you get on a labor ward and ask a midwife or a doctor, who is this patient? The moment they say, oh, we don't know who this patient is, that is the first sign of an unsafe labor ward, and that is when problems happen. And lack of situational awareness is the having of problems, the having of maternal mortality, having of infant neonatal mortality. So we need to be constantly aware. It allows us to maintain a big picture. Now, there are various color codes, like when people are absolutely unaware of what is happening in the labor ward, that's a dangerous situation. When there are women on the labor ward and the doctors don't know about, the midwives don't know about, that's a totally dangerous situation. So we need to be constantly aware. We need to heighten awareness. For example, if a woman is in second stage, has been pushing, and CTG is becoming pathological, there should be a doctor in the room waiting to offer an instrumental delivery. There's a heightened level of situational awareness. So we move through various levels of situational awareness and task focus on labor ward. And all of this is informed by a handover. So we do it at the start or at the end of a shift. And we normally want to find a quiet room free of distractions to do our handover. And everybody attends the handover, from the obstetric team to the neonates team to the anesthetic team to the theater staff. What is not a handover? I've heard stories where people just tell the incoming staff on the staircase that, look, there's nothing happening on the labor ward. or it's just one or two cases, no specifics. That is an absolutely untenable situation and a dangerous situation. Discussing cesarean sections in the past 24 hours without mentioning which cases are on the labor ward, which of them are high-risk patients, which of them are ongoing inductions, etc. It's not a handover. You've just discussed past events. We do not know what to anticipate on the labor ward. We do not know which emergencies are going into theatre. And it's important that the entire on-call team shares the same mental model. Everybody in every clinical area for the on-call team knows what is happening. So that if somebody is admitting patients, they know that there's an emergency on the labor ward. They know that the bed situation is like this. They know what the court situation are. Meeting to discuss general problems in the department is not a handover. So generally, there's a framework for handover, which is a structured multidisciplinary intershift handover. And it has three components: the pre-handover, the handover itself, and the post-handover. And it taps into the flawless execution cycle used by Air Force pilots. So what is flawless execution? It has 5 pillars. You plan, you brief, you execute, you debrief, you win. So planning, say that it influences destiny by being proactive. By planning, you're being proactive. By briefing, you know what the mission is. By executing, you know where we are and what we want to do. You debrief and you win. So these are the 5 pillars of flawless execution. You determine objectives with your plan. You come to your brief, you set out your objectives, you brief on scenarios, you set out your standards and what you want to achieve. When it comes to executing, you set out your work list, you cross-check your list, you monitor the work. When it comes to debrief, you set a time and location and you analyze how execution has been done against objectives. You try and align execution. And then you recognize your successes and you celebrate them. So with the Smith model, the pre-handover equates the planning process of flawless execution. So before the handover, the on-call team collates salient information about all the patients on the labor ward, patients in gynecology, patients who are going to theatre, inductions that are ongoing, and put all that information down. Laboring women are informed that the incoming team will be coming over so that they are not taken unawares. You try and maintain a sterile cockpit, and this is from aviation where we know that distractions are not having of a disaster. So you take away all distractions during the time of taking off and landing, and we take the whole scenario into healthcare: a time of taking off, a handover, and a time of debrief, a handover. Minimize distractions. We know that just verbal handover alone, only 33% of information is transferred. So close to 70% of information is lost. And this is critical because it's a safety risk for patients. So you try and take notes, or you even bring a pre-printed sheet which transfers most of the information from one team to the next. And we use the sharing framework for handover. So we know the staff situation in the labor ward. Are we understaffed or overstaffed or adequately staffed? Which high-risk situations do we need to pay attention to on the labor ward, in antenatal and postnatal wards, in ITU? Are the patients waiting to go to theatre? How many patients are on the elective list? How many outliers do we have? How many inductions are ongoing? How many are coming in today? Is on neonatal beds open? Do we need to do in utero transfers? What is the gynae wards looking like? Any emergencies going to theatre? And this should be shared with the entire on-call team, not just in isolated areas, so that everybody is sharing the same information. Everybody has the same awareness, and that is what we call a shared mental model across the entire team. The language that should be used at the handover is the SBAR, where we talk about the situation, the background assessment and recommendation, so that you give a set of recommendations to the on-call team. Identify patients by name and location so that they can go directly to the patients. We use closed loop communication when information is given. If you don't understand, you give information back and it's confirmed by the giver of the original information. so that we all know that we understand the same things. At the post handover, we have a job list. We give individual responsibilities and we give time frames for those jobs to be done. So at the end of handover, we should know that you are going to bed 1, you are going to theater to do the emergency section, you are going to assess the CTG, you are going to do the instrumental delivery, you are going to do the perineal repair. And we know this, and then we set time frames to regroup and share a mental model, update each other, and move on. So that's essentially what a handover should look like. Anything short of this becomes a safety problem for the department. Thank you.